Good afternoon, everybody. My name is Dalton Witt. I am the Communication and Engagement Coordinator for Glenbeigh. So I do a little bit of outreach. I do some staff training, new hire onboarding. I work closely with our partnerships like Ford and Norfolk Southern, and as far as our EAP, our employment advocate programs at Glenbeigh. I was a counselor for many years at Glenbeigh. So it's my honor, my privilege to speak with you all for Alcohol Awareness Month. And I'll kind of incorporate just maybe substance use disorder in general in a lot of this conversation. So for 42, 43 years now, Glenbeigh has offered inpatient services for substance use disorder in Rock Creek, right down the road from us here in Ohio. Listen, I grew up out here. It's not the edge of the world, but if I take you to the roof, you can see it from there. So that being said, we serve about 2,000 patients a year for substance use disorder, and we are inpatient residential, but we also have outpatient centers, which we'll talk about a little bit at the end. So the topic or the idea for the day is substance use substance use disorder in honor of Alcohol Awareness Month. And, we do live in this era of the opioid epidemic, right? And drugs, especially with opiates, they reach every socioeconomic class now, right? It's in all of the neighborhoods. It's touched everybody. But to this day, especially for an example, at Glenbeigh, we treat more alcoholics annually than we do every other drug addiction combined, right? So the fun TV commercial or the medication we can prescribe you to come off the opiates. So it's always the discussion on the drug or the opioid epidemic. But really, alcoholism is the crushing substance use disorder in the United States and really in the world, right? It's been around since the beginning of time or recorded human history. We can go back about 5,500 years to Mesopotamia, right? Modern day Iraq. And we have Babylonian texts that talk about fermenting of the grape and what it does on society and stuff. So this is, for as long as humans have been humaning, we've been enjoying fermented fruit, right? So it's part of our experience. The Chinese started distilling alcohol at the turn of the century, so about 100 AD. There's always a common misconception that the Irish were the first to distill alcohol. It's a very common tale. It's not true, right? So the Chinese were the first to do it. And now we live in the age of, let's see, I want to say, I'll have the quote earlier, but I think we saw a 35% increase of alcohol sales during COVID that has not receded since then, right? So it is the medicine. So Glenbeigh itself, we're a HX Guardian of Excellence Award winner. So what this is it's a survey system where out of 42,000 hospitals that were surveyed, we placed in the top 4 percentile for patient experience. So we're really proud of what we do at Glenbeigh. We are a standard, and hopefully we can relay a little bit of that in this message today. So the mission at Glenbeigh is to provide the highest quality of healthcare to those in need of alcohol and drug treatment, and to support ongoing recovery efforts, right? So this is through our outpatient centers, through a step-down level of care, which is, you've heard of maybe IOP or OP, which is outpatient therapy. So this idea of not only serving someone when they're in with us, but after as a step-down level of care. The best way to look at it would be if you were to break your leg, you would go to the hospital, you would be inpatient, and then once you left, you'd probably go to physical therapy for a few months after that. That's kind of the best parallel lane to talk about intensive outpatient therapy. And the reason it's called intensive is it's a few days a week. And this idea of we're transitioning out of a 24/7 care facility back into our life. And then the hope is to step out of our life for a few hours back into a group therapy or a talk therapy session, right? So here it is. So the most recent numbers we have were released in late 2024, which would be collective data from 2023. So that's the most recent numbers we got. So about 48 million people here in America, 12 and older, report to have a substance use disorder, so any substance. including about 28 million for alcohol. And then we have 134 million here in the US that self-report to be binge drinkers. So this would be, I mean, binge would be probably anything over 12 a week, right? So really what we would call an issue would be probably 6 to 12 a week, right? So 1 a day, or 3 to 4 on a Friday, 3 to 4 on a Saturday would be considered a danger zone for alcohol consumption, believe it or not. At that lowest level of alcohol consumption, you still receive brain deterioration, right? So for a long time, it was thought that only heavy drinking caused that. But we know at the most moderate levels, 1 drink a day, or again, maybe 3 on a Saturday and 3 on a Sunday, you can still have a reduction in a white and gray brain matter just from that. You know, make no mistake, alcohol is a poison. There's no version of any healthy benefit, period. There's a lot of cultural nuance where people want to say it's beneficial to certain parts. It's not. There's no version of it. It's the most empty of an empty calorie, too, for the fitness people would understand this, right? So just the process of the caloric reduction of it being in your body, there's no benefit from. So there's no vitamin retained. So all of it is just a poison process, and that's actually what gives us the diminished state, which we think of as buzzed, is our body fighting a poison. So marijuana is the most commonly used illicit drug in the country, 61 million. This has gone up about 13% in the last year, which is a wildly alarming number, right? We've seen 1% on heavy years, a 2% increase in the last decade for marijuana consumption. So from 2022 to 2023, we saw a 13% increase, which is crazy, right? So as we lower the consequences of possessing marijuana, right, and using it more for medicinal purposes, and now we see it more recreationally too, right? So, survey conducted. So SAMHSA is a Substance Abuse and Mental Health Services Administration, kind of the oversight board for what we do as far as rehab. SAMHSA found that more than 95% of people who needed rehab in America in 2023 did not get it or could not go. So it's a pretty exclusive group of people that actually get help as far as inpatient treatment. So I put this one up to kind of, we all know the message, right, of the opioid epidemic. If you're alive in the country in the last 10 years, we know this conversation. But no one's really talking about the truth, which is alcohol, right? It's an easier sell when it's an illicit drug, right? And it's these darn doctors that got everybody on it. We have a little bit of escape on the blame on that one. We can prescribe medications to come off of it, right? This is a really dynamic conversation, and it is a killer. But what we see is about 14% of deaths are from other drugs, 14% from opioids, and 71% of all recorded addiction deaths are from alcohol. So again, this is the conversation no one's having in today's world. Alcohol, most used substance among minors and adults in our country. It's the 3rd leading cause of preventable death, which is another wild statistic. Alcohol directly can cause 7 different cancers. There's a lot of debate that it might be more than that, but we have enough empirical data to show that 7 different types of cancer: esophageal, breast cancer. Alcohol consumption directly causes breast cancer in women. Pancreatic, and of course in our intestines, and on the list goes. The throat cancer is a big one. That's another one of them. So 7 cancers it causes. But really what we see is the social effects of alcohol consumption in our country, right? So 40% of convicted murderers and convicted violent crime used alcohol either during or directly before the crime was committed itself. It's almost half. That's a wild statistic. 37% of all sexual assaults and rape are committed by offenders who are under the influence of alcohol. And 13,000 direct deaths on U.S. roadways from alcohol-related accidents. So the indirect numbers are a lot more than that, but these are get a little harder to correlate studies. So direct death would be the blood alcohol content of someone in an accident killing. But we have the indirect would be a lower blood alcohol content, relayed reflexes causing an accident, right? Those aren't categorized as direct deaths. So 70% of alcohol-related violent acts occur in the home. So 70% of all violent acts in the home include alcohol. This is crazy. A third of all suicide deaths are linked to alcohol in our country. Suicide is the second leading cause of death for men now in our country, 45 and under. 4 to 1. So there will be 4 male suicides for every 1 female suicide in America this year. More U.S. men will die of suicide than women will of breast cancer this year. This is kind of the, when we talk dual diagnosis, right, the mental health aspect of all of this as well. This is a tough one. 10% of all U.S. children live with a parent who has an alcohol use disorder. So that's about 7.5 million kids here in the U.S. live with a parent who's struggling. We talked about the 35% sales increase in alcohol during the pandemic, which again has not receded, has not come back down. And 70% of all substance use disorders have a co-occurring, right, which would be so alcohol and opiates, or alcohol and cocaine, or alcohol and Valium, right? So most of it's going to usually be co-occurring. And again, that number earlier that we treat more alcohol use disorder than all other drug addictions combined at Glenbeigh, that's why. So it's a co-occurring. 30 million adults surveyed 18 or older perceived that they had a substance use problem. Among them, about 22 million considered themselves to be in recovery or to have recovered. That's pretty good, actually, for us. Those numbers have gone up quite a bit in the last 20 years. So this is a problem. It's a complex experience, right? It's a complex process. Studies do indicate that up to 75% of people who suffer from a substance use disorder, or I'm sorry, alcohol use disorder, will experience recovery. And the key word in that one is eventually. Right? It's a tough process. Most people won't win at something in their first endeavor, period. Right? I think there's an unfair correlation between getting sober and not having to experience multiple failures, right? Anybody who's good at anything, stumbles, falls, repetition, drill, practice, right? This is the tough part of the tough stigma of recovery is people will try it once or twice and say, well, it's not for me. I'm no good at it. It didn't work out. When in any other endeavor in adult life, right, that would be a drop in the bucket from how many times we'd have to experience whatever process that is. If all of us were going to go out here and learn how to play cricket in the parking lot, we'd probably stink at it more than 2 times, right, before we ever got a competency for it. So there's a really weird uphill battle with recovery in this sense that, like, we just think we should be good at it. And I think as a recovering alcoholic and drug addict myself, I think the trouble is I see people do it with impunity, and I wonder why, and I wonder why I can't experience that same thing, right? Whether it is to consume alcohol, right, or to be the weekend warrior, or to be somebody who lives in abstinence. And a lot of times I think I'm more capable than that person. Why can't I pull that off? So there's a really weird, unhealthy expectation that we put with that part of the process. There's a great University of London study that shows University of London started tracking about 65,000 people in the 1960s. And it's a meta-analysis study, right? Just everything. But when they whittled down the substance use disorder numbers, what they found was usually by 13 or 14, they could figure out who were going to be involved with substance use disorder. Usually it started with a bit more experimentation at that age with alcohol or marijuana. They also found, on average, the people who suffered from a substance use disorder had an IQ that was 5 to 8 points higher than the rest of the general population. So usually the next question is, Dalton, if their IQ is so good, why can't they make better decisions? right? Because IQ really has very little to do with your capacity to function. EQ is what we need to talk about. So if IQ is intellectual quotient, EQ is emotional quotient, right? So really, the alcoholic or the addict struggles with EQ, emotional quotient. The best way I've ever heard it put is if IQ is a sports car, EQ is the driver. Right? So we could have the baddest machine ever, right? But if we can't drive that machine properly, we end up in chaos or trauma, right? So the rates for substance use disorders are similar to the rates, relapse rates are similar to any other chronic medical illness. What's a chronic medical illness? First off, it's something that doesn't go away on its own. Diabetes, heart disease, epilepsy, right? These are chronic medical illnesses. To be categorized as chronic, it's usually something that would last more than a year, and it cannot go away without some type of outside influence or medical help. So, interesting that the relapse rates are about the same. So for that person that's trying to get their blood pressure under order, right? They've gone to the doctor. They say, hey, you're putting yourself at risk. You're taking 10 years off your life. Don't you love your kids? Eat better. Don't consume as much salt. Exercise regularly. Get your weight down. Same success rates for drug addiction and alcohol addiction. Right? So again, we put this in this pedestal, or we lump it in this separate category of it's such an obvious, the consequences to your life are so obvious. Why can't you just do better for your kids, right? When really all that is a sign of how ignorant we are to what the disease of addiction is, right? To make that assumption that we know anything about that or that has anything to do with decision making. So I love that stat, 40 to 60% relapse rate in pretty much all other chronic illnesses as well, right? Some studies suggest that roughly 70% of patients who complete alcohol rehab are still sober 9 months after discharge. It's an awesome number. Unfortunately, there's also studies that show about 70% of us that make it to a year will relapse at a year. So that's a on-the-nose correlation, right? So at 9 months, we have a 70% success rate. But what the studies show is between 11 and 13 months. 70% of us in recovery will relapse between 11 and 13 months. And now we could have an hour debate here about why we think that is, behavior issues, mental health, or we could talk about what worked for us at 3 months isn't working for us now at 9 months, right? So there's a lot of conversation and debate for that. Unfortunately, just as how different we all are, probably the answers are all different as well. This is the trouble. This is what puts recovery in the category of health and fitness, in my opinion. I think the closest parallel conversation is fitness, right? We actually see some of the same success rates for health clubs. I'm sure June could talk with us about that, right? The New Year's resolution season, right? And then the trickle down to we're back to our 10% base that come every month, right? So drug and alcohol recovery is a similar process, right? Because it is that internal X factor, whatever that is, that makes people have a behavior change. So for drugs, between 85 and 95% of people who successfully complete drug rehab report still being abstinent at 9 months. So again, I can tell you from my personal experience, getting sober is not the hard part. Staying sober is, right? So as we saw the recidivism rates earlier. All right, so why don't these people just make better choices? I love this part of the conversation, right? And I, even as a professional and someone who does this for a very capable company, I at times will slip back into that behavior, right? Where I'll slip back into these assumptions about make better choices. Don't you want to have a better life? But really, what we're negating the brain science of addiction, right? So the rewiring of the brain. That's really what happens. So the brain change is the biggest issue. We can show in CAT scans and MRIs that people that suffer from a substance use disorder like myself, our neurons in our brain fire in a different order than people that don't have a substance abuse disorder, right? So this is the reward system. Everyone's heard that term a lot. Or executive function in the front part of our brain, our prefrontal cortex, right? So it's an altered reward system. Everyone talks about the reward system, but it's also an altered control system. When I talked about executive function, That's what happens. It gets rewired up front. A great parallel conversation is type 2 diabetes, which used to be called adult diabetes, right? But we've changed that term in the last few years. All right, so type 2 diabetes, which we can do to ourselves, right? I can, through poor lifestyle and eating, I can cause that illness in my body. And so there's a rewiring very similar in the brain to that experience through extended habitual alcohol consumption, which could be as low as 1 to 2 drinks a night, but over a continued time span with the brain degradation, right? The rewiring of the reward system. That it doesn't happen as aggressively if I'm a binge drinker. I'm going to get it done quicker. But Stanford has studies now that confirms that very small but habitual, right? Alcohol consumption can still create that over a long term. So it makes it difficult to prioritize long-term goals over short-term goals, right? Now, this is the reward system, right? I feel uncomfortable. I need some relief. I should get drive-through at McDonald's. Oh, wait, no, I'm sorry. We're talking about substance use. I should have a drink, right? It's all the same. We could have a great conversation with this first bullet point about your cell phone. Right? If you want to understand what substance abuse disorder feels like, let me take your cell phone for the next 4 hours and leave you in this room. Most people will be restless, irritable, discontent, frustrated, right? Those would be signs of withdrawal. So we figure about half of our entire population, adult and children, half of our entire population here in the US has some type of unhealthy addiction to their phone. Now, it depends on, it breaks down to apps. Social media apps is in the 70 percentile, down to messaging, which is in the 20 percentile. The average American lights their cell phone up 400 times a day. So addiction, right? So if we go away from the 2-inch view of substance use disorder and we go to the 1,000-foot view about addiction, all of us have a higher power than some type of addiction. It's our phone, it's our food, it's our judgment, right? We have lots of studies that show we get addicted to judgment. Your brain will give you a little bit of a dopamine hit every time you judge someone else, right? So now the reward system is rewarding us for being stuck up and snobby about other people, right? So this type of conversation can go on and on and on. I actually believe I'm one of the lucky ones that my disorder was substances. So there's a great network of meetings across the world and a great resource system to help someone like me. God forbid my primary issue was judgment. That would be a tough one to solve. So the compulsive behavior, right? Seeking versus consequences. For most of us, again, from the outside looking in, the consequences conversation is legitimate, right? It makes perfect sense. This behavior isn't serving you or your family anymore, and it's causing problems, right? Which is really the definition of addiction. Once we do something compulsively, even when it causes negative effects in our lives. Cell phones, right? Most of us will have a relationship problem because of our cell phones. That would qualify as an addiction, right? So this idea of the food issue, right? So it's negatively affects taking years off my life, my high blood pressure, my cholesterol, right? My diabetes, right? So it's the same conversation. So the consequences conversation on if we could do a sliding scale of the most effective ways to address something like this, that's at the lowest bottom that we can possibly find. That being said, I stand here with almost 10 years of uninterrupted recovery because of consequences. So I feel kind of weird always having this conversation with people. I would love to talk to you about the decriminalization of people like me. But at the same time, it was because of the court system and getting in trouble that I was able to get sober. So for me, that our argument sounds like intellectually sound, but my life experience is different. So the seeking part too, right? Remember the rewiring of the brain. This behavior becomes, have you ever heard, like, I'm really good at handling chaos, but then I realized I create most of my own chaos, right? That's a common tale in psychology. Same is true for the addict or the alcoholic, right? We get really good at managing this madness, but we become really addicted to the madness itself, right? The constant stimulation of the seeking, the hiding, the having to get it. So, of course, the impaired decision-making, impaired judgment, decision-making, self-control, and managed impulses. I don't think that's a healthy argument for most adults just in general. Most people don't manage impulse control well. But when we come to the mental health disorder, right? The actual brain disease of addiction, which is especially alcoholism, has been categorized as a disease since 1952, right? So the disease of alcoholism, self-control is out the window, right? Managing our impulses is out the window, right? The cost-benefit reward analysis of decision-making is out the window, because it stirs a very primal part of our midbrain, where we get into this is the center that operates fight or flight. Right? So now we're in this constant, it's not a want, it's a need, right? This is where we get kind of in the zone of it's almost the paranoia of something bad's going to happen if I don't. So also, the reason we can't just tell people to make better choices is there's risk factors, genetics. When I first came on board with Glenbeigh 8.5 years ago, the best studies I could find said that addiction was about 30% genetic, that it would just be in your genes. Sorry about your luck, you didn't win the lottery on this one. Studies that have been released the last 2 years now are showing that number as high as 60. So we think a substance use disorder is about 60% genetic. Crazy. So we could do everything right, but still have a higher than half percentage rate of just developing an issue later on in life just due to our genetics. We know we can track it in studies, but we're not sure where it lies in the gene. Right? It's just, we haven't figured that out yet, but we can take NICU babies at birth, remove them, put them into foster care, and they still have a 60% higher rate of addiction later on in life. So, environmental. This is pretty self-explanatory, right? The socioeconomic part of this, depending on where you live. Access to health and services, right? Your sense of what your future looks like. Environmental is very much my idea of what my future could be. And not everyone lives in an area where they understand that there's opportunity, you can do anything you want, we can overcome this and maybe even turn around and use this issue that I had to help others and make a career out of it, right? So depending on our sense of what our future could be like, that's an issue. Psychological, of course, the dual diagnosis we talked about, right? So my anxiety, depression, bipolar, ADHD is, there's some really interesting work going on right now that correlates super massive numbers with ADHD, attention deficit hyperactive disorder, and addiction. So I've been assessed by a couple crazy quack doctors that want to tell people I have ADHD, but I don't buy it. So, all right, so, and of course, just the increase of the vulnerability. So withdrawal symptoms as well. Why can't we tell people just make better choices? This is, anybody in here try to ever quit caffeine? Right? Anybody that we're talking to ever try to put sugar down? I've met a lot of people that will tell me they're off sugar. No, you're not. Right? I've seen athletes do it where to really detox yourself off of sugar over 7 to 10 days, you become physically ill. Right? Physically, to really get to a zero sugar, which is pretty impossible. But athletes can do it. There are migraines. It can be vomiting, right? So this idea of a withdrawal symptom, we put it in this weird category where these alcoholics are going to withdraw. Look what they did to themselves, right? You would have to withdraw yourself or detox from your phone addiction, right? You could go right now and Google, how to reduce my phone time, and there's going to be step-by-step instructions that will sound very similar to any other addiction. Limiting time, decreasing, don't just cold turkey it, right? Decrease a little at a time, right? So again, this isn't some special thing, just substance use disorder, which is what we specialize in at Glenbeigh, isn't really such a rare conversation when we talk about addiction in general. This is an important one too. Why can't we just tell people to make better choices? There's a great psychological term called learned helplessness. Right? A lot of people will suffer from learned helplessness at some point in their life about any myriad of topics. All the good ones are taken. That's a learned helplessness. Out of the 8.5 billion people on the planet, you really think that? Right? So, it doesn't matter what I do, I have bad luck. That's a learned helplessness. Also, in this type of conversation, I've been to rehab 4 times. I've relapsed 6 times. Doesn't matter what I do. I don't know if recovery's for me. Just remember earlier we're talking about playing cricket. How many times would we have to lose, right? So 6 times out of a lifelong lived doesn't sound like heavy math to me. But we tell ourselves a narrative that it's hard to do, right? You might experience this with weight loss, fitness, getting your finances in order, right? So the learned helplessness conversation pervades most of us. But in addiction, we're going to tell ourselves, in recovery, in 12-step recovery, they refer to this as the prison of uniqueness, right? Let me tell you why it's different for me, right? And we do this, again, with a lot of aspects of our life, right? In psychology, they would call this personal exceptionalism. Let me explain why I'm personally the exception to, right, the God conversation or the higher power conversation. 12-step meetings, talk therapy, social reacclimation with others, right? Whatever thing you want to talk about. So one of my favorite parts of the learned helplessness conversation is there's an inverse to that, right? In order to develop the idea or the theory of learned helplessness, you have to have its inverse, which is learned optimism, right? So most people aren't born optimistic. It's a learned skill set. So we can actually convert this over a time period, talk therapy, support groups. We can take that learned helplessness and transition it into a learned optimism, right? The best metaphor for the learned helplessness is the elephant at the circus as a baby is tied to a 3-foot post in the ground. And as an adult, as a 6-ton machine, as an adult, they tie it to that same 3-foot post. That's a learned helplessness, right? So that elephant learned long ago when it was tiny that it couldn't pull that post out of the ground. So now, as a 6-ton adult, it doesn't even attempt it. And the last one, I think maybe the most important one, stigma and judgment. And I'm not talking about our judgment of the alcoholic or an addict. A lot of times I'm talking about the self-imposed judgment of an alcoholic or a drug addict, right? A person who suffers from alcohol use disorder or substance use disorder, which would be the term of that. The terms we're supposed to use today. So this idea of stigma, if I'm a professional, right? So I can't step away from work. No one will trust me if they find out, right? We do business classes for our business professionals at Glenbeigh, and this is a topic that comes up a lot, right? Disclosure. How much do I disclose when I return to run my sales team internationally, right? Which really everybody probably knows. We're the last ones to the table on that one as alcoholics and addicts. But anyhow, so this idea of the stigma and the judgment, this comes to family as well, right? I just can't bring myself to have this conversation with my family. Right? Or if the conversation is not done properly, it sounds like judgment to me when I'm thinking, listen, I know what you've done in your life. Who are you? Right? The person making the approach must have their house in order. So isolation. There's a great TED Talk by Johann Hari who breaks down addiction pretty well. And at the end, he ends with one of the most profound statements on addiction I think that exists, which is active addiction is isolation and active recovery is connection. So a lot of times we will, the disease of addiction isolates the sufferer, right? Through the stigma, through the judgment, through the psychological issues, right? Through the prioritizing different things that society's not prioritizing now, right? We'll separate ourselves from the conversation with others. Probably through a guilt and shame as well. So, and then of course, we started with consequences and we'll end with consequences. It's the weakest argument. It just, like, if people getting in trouble was enough to curb addiction nationally on some, right, on like a measurable scale, that would have worked over the last 50 years of the war on the drug addict or the alcoholic. Right? It's not a war on addiction, it's a war on the addicted. And that's just not, it doesn't work. We have studies from Portugal for the last 30 years that changed their entire system, decriminalized everything, but took all of the funding and redistributed that funding into workplace programs, resocialization, right, connection, and it's not even arguable, right, how well it's done. But that's a big conversation for another day. So how do we help? Right? We talked about why just make better choices is a really ignorant thing to say to somebody. Right? Exposes our ignorance. Right? If we can't watch a 15-minute YouTube video on what the disease of addiction is, we shouldn't talk to people about their addiction. So how do we help, or how do we do this? First and foremost, we have to show compassion, right? Active addiction's isolation, active recovery is connection. We got to show some compassion. It's hard to do. I'm a tough love guy myself. I was helped by tough love people. But some compassion, like, hey, this is a winnable fight, and you're not the first person. You're not special. This has happened since the beginning of recorded time, right? So to not lecture, shame, or threaten, this is a tough one, the threaten piece. If we can't do this, you have to move out. There's some validity to that, right? The alcoholism and drug addiction is a family illness in the sense that it disrupts and interrupts the family, right? So this idea of sometimes we might have to, instead of threaten, I would categorize it in boundary setting, right? So setting healthy, rigid boundaries for someone. Yeah, but we can't lecture, and we definitely can't shame people. I grew up Catholic, so I know about that one. But shaming others is a pretty low intellect tool as well. Not a lot of intellectual horsepower behind that, right? So anyhow, we'll jump off that. So to self-education, this is important. We live in the day and age, our cell phones are 100 million times the computing power of the computer that took us to the moon. All information is always available, right? So to just like make assumptions that we watched a Hallmark show once about the alcoholic husband and the doting wife, that we know in some way that we can comment on it to someone else is pretty bold, right? So we should educate ourselves a little bit on that. We can't assume that we know. We got to time our talk right. Most of these talks happen when people are heated or elevated, right? We're in the middle of a fight. This has happened again. You didn't come home till 2 in the morning, whatever it is, whatever the issue is, right? So we handle it in an elevated state, right, where people are in fight or flight or combative, right? Most people don't argue to communicate. Most people argue to win. So on the most basic stage, we're going to try to win that argument. And, right, what's the old life hack? Do you want to be right or do you want to be happy? Because those two things are pretty exclusively mutual. So this idea of timing the talk right, being purposeful, proactive, not reactive, right? Playing chess, not checkers, right? Strategy. Coming up with a way, doing some research ourselves, maybe even calling. There are therapists all over the country in every town and hamlet that specialize in doing this type of things for families. Most people will be able to coach you over the phone, right? You can watch a YouTube video on it. So doing our homework and timing that talk the right way. Some of my family members, I had a sibling who was pretty clever, did it over dinner at a public place. So I couldn't get loud and he couldn't get loud, right? He's a big guy like me. We like to get loud. So that was pretty clever on my brother's part to do it that way. Made it a bit more effective. I couldn't get up and walk out. So anyhow, well, I guess I could have. Anyways, lead by example. This is a tough one. So the person making the approach has to have their house in order. So if I'm a daily drinker, but I need to criticize someone for their drinking, it's a pretty flimsy argument to be on, right? So this is a tough one. It's hard to talk to people about making better choices when maybe I haven't figured this out in the health and fitness in my life or my finances, right? Which are all very similar issues. So the toughest one is to stop covering their tracks. Right? The alcoholic mess maker and the doting family member. Right? This was the basis for what we know as codependent. In the very beginning of codependency, that was a term that was created to describe a person's relationship who is in active addiction. Now we know that codependency can be a learned behavior through environment, that kind of stuff. But 100 years ago, if you were codependent, one of the two people had to be in some type of active addiction. So this idea of the covering of the tracks, the mess cleaner upper, right? And it's hard because we love people and we want to help them. But we can also categorize this as enabling. That's a tough one. So we talked about it a little bit earlier, right? Ask for help, support. This is hard on everyone. There's so many tools and resources out there for people. We can educate ourselves. We can do I'm going to bring it up again, right? You can build a house or take out your pancreas through a YouTube video, right? So we should be able to watch a video on this, which is very easily done as well to, again, self-education, right? Which is the world we live in today. All information is available now. Can we self-educate? And then to get support, right? Call your local Alcoholics Anonymous. Every county's got an office or a department. Call them. They can give you resources. They can connect you with Nar-Anon, Al-Anon, which is 12-step programs for people that love or have family members that are in active addiction. And then also we got to remember the 3 C's of Al-Anon, which is you didn't cause it, you can't control it, and you definitely can't cure it. We got to put our egos aside. Right? I know we want to say, if you loved me, you would do better, which again is a wildly entitled, egotistical thing to say to somebody we love. Right? We say, how can we help? Right? I don't understand this fully, but I want to help you. Are you willing to let me help? Right? So, but we can't shame or control. So Glenbeigh, that's what we do, right? Some pictures of the site. A lot of times pulling people out of their social setting and placing them in a different social setting is important. Remember earlier we talked about active addiction as isolation and active recovery as connection. So right now we have about 120 patients on the property at Glenbeigh living in our residential facilities or in the hospital. Right? So to take someone out of their social scene of ducking people at work, hiding from the family, insecurity, isolation, and to place them into a place not only with professionals that can accommodate, but also other people that are having a similar life experience, reduces the chaos, right? Makes us feel less, remember we talked about unique, breaks down the terminal uniqueness, right? Strength in numbers. So the services offered at Glenbeigh are, of course, the big one, diagnostic evaluation. Not just anybody can come to rehab. We got to evaluate you and make sure this is legitimate, right? It can't be fraudulent. So this is where we get our partnerships with people like Norfolk Southern or Ford, where we have a work placement program. They get assessed, they come out to Glenbeigh, and then we have people in our infrastructure in place to get them their disability payment or their FMLA while they're out of work, so they can get paid while they're in treatment. Right? There's a lot of different moving parts to this, and a lot of that begins with this evaluation piece. Right? Is this appropriate, this level of care? Because remember earlier in the beginning, we talked about step-down level of care, outpatient therapy, 4 nights a week in a classroom, right? So there's different levels of care that we have to deem appropriate. Withdrawal management is the fancy pants way we say detox now today, right? Language is constantly changing in any business, in our business as well. So withdrawal management, most patients will come in and need some type of medically supervised detox. Right? Does anybody know the 2 substances that can kill you coming off of them? The first is the most obvious. Alcohol, we're talking about it today. The second's a little sneakier. Does anybody know what it is? Benzodiazepines, Valium, Xanax, mommy's little helper. Right? Those are the 2 things that can actually make you die coming off of them improperly. It can cause seizures, and we can die from those seizures. As a recovering opiate addict myself, I could be very, 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 very sick for a lot of days, but there was no immediate danger of death from that detox. Right? So, of course, inpatient rehab and our dual diagnosis. We talked about this earlier. Anxiety, depression, bipolar, ADHD. So we have psych services as part of the onboarding process for our patients as well. We bring them in, we get them medically down off the ceiling, right, in our hospital, and then we pair them with psych, right? Let's find out what's going on. Most of us are going to have something running parallel to this: anxiety, depression, and those things can be reduced through recovery, right? But at the time of this sea change, we're probably going to experience something other than just the physical ramifications of our addiction. So partial hospitalization, we would essentially step down from withdrawal management into partial hospitalization, right? For a couple weeks while we're still in the hospital, we're still getting follow-ups with medical, right? We're making sure everything's okay. And then we would As we discharge successfully, we would immediately make a warm handoff to inpatient or intensive outpatient therapy. This is what we talked about earlier, 2 or 3 nights a week or in the mornings. Kind of like we used the example of we broke our leg, now we're going to physical therapy. This would be the physical therapy part of the journey. Family services is something we're very proud of at Glenbeigh. We actually just this past weekend reinstated our on-site family services on Sundays, where family members are allowed to come on to the campus. We actually have an educational day track set up for them where they go through lectures, they go through groups themselves, they have lunch with the patient. This is something we are really excited about. It's something we were known for years. Then during COVID, right, things changed. At one point we got down to like 24 patients. We didn't know if we were going to stay open. It's hard to have a residential facility, right, while COVID was going on. So obviously we had to lock down. No family members could come on the campus, and it's taken this long to restart this part of the process. So, but we're so excited about it. Also, we have our family services. So when the patient is inpatient, we have people that are specialized in family therapy. So if I had a patient who's having a lot of struggles with their spouse or their parents, we can schedule them with this counselor that specializes in that tool, and we can do telehealth calls, that kind of stuff, right, where we can get together and collaborate with the family. Also, we do have family services in our outpatient centers as well. So most of our outpatient centers, 1 night a week, has a family night, where not only the patient comes, the client at that level. The client comes, but then they can bring their family member with them as well. Because this, again, is a family disease, not only in the genetics of it, but in the disruption of the family. Continuing care, this is another step down level of service. Aftercare, right, where we're 1 night a week, right, we're just checking in. We've pretty much reinserted ourselves into our life by now. Right, we're 3-4 months out, but we're coming back 1 day a week for an hour-and-a-half session where we're just checking in with a clinician. Hey, this is where I'm at right now. Right? This is where we're going. And then, of course, community referrals. This could be trauma therapy, psych services, dietary, all kinds of stuff that we try to create as soft as a landing as possible for our patients once they leave our care facilities. Our specialty focuses at Glenbeigh. First and foremost, gender responsive. We're male and female. The treatment center I went to was just male, right? So we have male and female combined services. So this is huge, right? The experience for a male is very different than the experience for a female. And not only our addiction, but probably the road leading up to that, traumas, mental health issues, that kind of stuff. So healthcare and nursing specialized services. So we're one of, it was 2. I think we're the only one now in Ohio. But I know the last I checked, we're one of only 2 rehabs in all of Ohio that's partnered with the state board that we can assess someone's medical license. So if you're an MD, RN, LPN, this is where they send you, to Glenbeigh. Right? The medical state board will send you to Glenbeigh. So we're pretty proud of that. So we actually have specialized groups for helping professionals, medical professionals, right? Not much unlike our business classes I talked about earlier. We have business groups, right? If I'm a traveling salesperson, right, or I run an IT team, my reentry to my professional life might be a lot different than if I work at Ford, right, on the floor. Right? So we want to accommodate all these different experiences. So of course, again, the executive and business professional groups. Our first responder groups we're really proud of. So this is police, fire, EMTs. This is another very different life experience. We see a lot of trauma from the job, right? Our firefighters, I won't even repeat out loud what I've been told, right, of the experiences they've had to have, right? So a lot of times we're blotting out those memories through our substance use disorder, right? Self-medicating. Also, we specialize for post-military as well, right? So we'll put them in with our first responders, but we have a clinician who's certified in that as well. So our vets can get the services they need. Pain management and education group, a lot of us, a lot of people that suffer from a substance use disorder, self-medicated for pain. Physical, not only emotional and traumatic pain, but physical pain. And then our LGBTQ plus support groups, this is important as well. We keep them off the schedule. They're held in private, but we have that resource available to people as well. And then our medicated, alcohol use disorder and opiate use disorder. So to help people medically off these, it's called a medical treatment, right? So we can put people on a long-term medical, prescription protocol that can help we can curb cravings. There's substances out there that we can use that can actually make people sick if they drink or use, right? So this is always an option for us as well. So our locations, of course, we have Rock Creek, which I've been talking about, which is our home base, but also we have sites in Rocky River, Beechwood, Niles, Canton, and then we have one in Pennsylvania and Erie. So these are our outpatient centers where we talked about the drop-down level of care. Right, so if I work for the engine manufacturing plant for Ford in Elyria, right, I can end up at the Rocky River. I can come in site to Glenbeigh and Rock Creek, and then drop down level of care after work, leave the Ford assembly plant, and hit Rocky River, Glenbeigh on the way out. So a continuance of care and also brand, right? So that way we're not jumping to another brand. Our outpatient services are in person, and we do telehealth options. We do have some people, we do some stuff with some of the coal miners in West Virginia that live in really rural areas. They're going to be on a computer or a phone for outpatient services. They're going to have to drive. Some of them would be 2 hours to get to a site. Again, the assessments. So sometimes we've talked about it. Not everyone's appropriate for inpatient. Sometimes people just need to go, right? We got a DUI. We were kind of getting a little loose. We drove when we shouldn't have. Maybe they're more appropriate to go right to an intensive outpatient therapy 4 nights a week. Of course, day and evening, continuing care. We talked about our healthcare professional groups and family education. This is a big part of this industry now is housing. Sober living, right? We have all of the studies that show people that transition to at least 6 months of sober living after doing a 28-day stay in treatment have like a 30% higher success rate. This is an Ohio statistic. So Ohio, at a state funding level, has put a ton of money where their mouth is on this. And we've been fortunate enough to receive some grant money to be at the tip of that spear, at the forefront of what Ohio is looking at for sober living. So we have 2 different sites at our Rock Creek location. 3 different houses. 3 different houses at Rock Creek that have up to 22 beds. 2 houses are for men, 1 house is for women. So I could actually apply. There's an interview process. And what happens is you would transition right out of inpatient therapy at Rock Creek to one of our houses that's on the same road. And then it's really cool. You can do a meal plan package. So you don't even have to buy groceries. You can come onto the campus area that's a mile down the road. You can come onto the campus, still use the gym. You're doing your outpatient therapy at Rock Creek in the evenings or in the mornings. You can stop by for lunch, breakfast, dinner, all that kind of stuff. So there's a great continuum of care, but also slowing down the reintroduction process to our lives. And then Niles, we have a 32-bed site in Niles connected to our outpatient center, same kind of deal. So I'll leave this up for a little bit to make calls or referrals. Before we end, I would like to see if anybody had any questions or any personal experiences with this that they'd like to comment on. Anyone? No? So we're always available. There's no inappropriate call for questions, exploration of resources, right? Insurance, what we take and what we don't. This is always in flux. It's always changing. This isn't Glenbeigh. This is state and federal insurance, right? So these things are always moving and in flux. Call us. We can help assess what the options are for you and deem what the next step would be for you and your family. Also, just as far as resources are concerned, locally, we can help with that as well. So if someone just is confused or has a question on where they can get help, we can always redirect people to the AAIGO, which is our local 12-step community out here, that kind of stuff. So I'll leave that up there for everyone. And if there's no questions, I'll wrap it up. Fair enough? All right. Appreciate all of you. Thank you, guys.